Because generally, whenever new phone or old phone, it doesn't matter. If the phone is new or old, if the signal is lost, it's sort of no use, right? The same way, the Stokes-Adams syndrome also is much related to this phase. Okay, first introduction. It is the sudden temporary loss of consciousness by brief cessation of cardiac output. Here, I have to highlight 2 points. One is temporary loss of consciousness, another one is brief cessation of cardiac output. Here, there is a brief cessation of cardiac output. It is not, the cardiac output is not, it's just a brief, okay? Another one is it is temporary. It is due to atrioventricular block. From the sinoatrial node, the impulse is coming to AV node. It came, which is normal. But if there is any AV block, or after AV block, if there is any blocks present in bundle of His or Purkinje fibers, it comes under infranodal blocks. In these 2 blocks, the ventricle fails to contract. Of course, the cardiac output is getting decreased. If the cardiac output is getting decreased, the blood supply to all organs, obviously, it's going to be decreased. First organ which is highly sensitive to hypoxemia is brain. So here the brain perfusion will be less. That is the Stokes-Adams syndrome. What are all the age groups commonly affected? Normally, it is generally Stokes-Adams syndrome comes under conduction system degeneration. So normally conduction system degeneration is commonly seen in old age because due to fibrosis or stone formation, old people are more prone to conduction system degeneration, but it is also seen in young children also if it is in hereditary cases. What are the symptoms? Before seeing symptoms, let us go for pathophysiology so that we can understand and we can interpret what is the symptoms. Of course, from the sinoatrial node, the impulse is coming normally to the AV node, but after AV node there is no conduction. Either after AV node or in the bundle of His or Purkinje fibers, so that the ventricular muscles fails to contract. If it fails to contract, it cannot supply, the cardiac output is getting decreased, the blood cannot be supplied to all organs, especially brain. So thus we are getting Stokes-Adams syndrome. So the symptoms are, there will be sudden unconsciousness because the brain is not getting blood supply, the brain fails to get it, so we are getting unconsciousness and the patient will appear pale because not only brain, other organs will not get blood supply, right? So that to maintain the pressure in peripheral organs, the vasoconstriction takes place so that the patient will be cold and pale. And recovery is typically rapid, and we know about Stanier's ligature, right? If the sinoatrial node fails to generate impulse, automatically AV node and bundle of His Purkinje fibers, and we know that ventricular musculature is itself a impulse generator. So it will, so that only I told previously, it is temporary cessation of cardiac output, because if AV node fails to generate impulse, automatically after a few seconds our Purkinje fibers and ventricular muscles and bundle of His also will generate impulse. So that only I told it is recovery is typically rapid. There will be no aura. Generally, epilepsy patients also has these Stokes-Adams syndrome patients mimic seizures because the brain failed to drive blood supply. But it also there will be mimic seizures. But in epilepsy patients, there will be pre-seizure warnings. They will weird smelling will be there. We can after that after seizures they will not get orient to the place and time. But in Stokes-Adams syndrome, it's not like that. If there is no any electrical conduction is getting disturbed, only blood supply to the brain is getting disturbed. So that after seizure they will orient to place and time. So there will be no aura. What are all the managements? First, due to cardiac output is getting decreased, there will be bradycardia. So if the patient came, we are in acute case, first we have to give beta blocker agonists, isoprelin and atropine to cure first bradycardia. The possible management and only management is permanent pacemaker therapy. Then what are the diagnoses? First, if the patient came, I was like, I have a mild convulsions, but I was normal now. Like that, if someone kept, or what are the interpretations we can do? First, we have to do 12 lead ECG so that we can identify which AV node or bundle of which is getting blocked, like that. After that, we have to do halter management, means if he is getting frequent bradycardia, we have to place mobile ECG in him, and we have to do tilted test. This test is to separate vasovagal syncope because they both have similar. So if vasovagal syncope was there or orthostatic hypotension is there, to rule out we have to use tilted test. If it is positive, we can go there. If it is negative, like because of the series of interpretations, we can come to a conclusion. What are all the ECG findings? Generally, we can see it is in Morbid's type 2 AV block and third degree AV block. If completely the AV node is not generating any impulse, it is third degree AV block. There you can see ventricle cannot pump and the cardiac output is getting decreased in that case. Another one is case is Morbid's type 2. In Morbid's type 2, we can see, in this diagram also we can see 1:1 ratio of QRS complex. One is normal, another one is abnormal. Like that, there will be a ratio. So that in Morbid's type 2 case of AV block and third degree AV block, we can see Stokes-Adams syndrome. And normally in left and right bundle branches is there, right? If these branches fails to generate the impulse, or if there is any bundle branch problem, we can see Stokes-Adams syndrome because the ventricular muscles cannot contract. That's it. I've just covered a gist of Stokes-Adams syndrome. Thank you.